Getting back to this, to her, to family, to friends, to hugs. For people at higher risk of COVID-19 complications because of diabetes, high blood pressure, and heart conditions, the COVID-19 vaccine is an important choice. Consider it's the first step towards getting back to what you miss so much safely. Getting back to life. Set your heart on it. It's up to you. A message from the American Heart Association.
All right, good afternoon, everyone. I am Jennifer Jager, the Executive Director here in St. Louis, and I'm happy to be here today to help moderate today's conversation. Today, we'll hear about the latest science and updates on the COVID-19 vaccine, and especially considering for those who have heart disease and stroke. We appreciate you being here with us today. The COVID-19 pandemic has had a devastating impact both here in St. Louis and throughout the world. As an organization deeply concerned about improving health, the American Heart Association has been actively engaged in fighting the pandemic since its early stage, providing funding for research and hosting conversations like this to educate the community. While this last year has been challenging, we are forever grateful for the support of our Heart of St. Louis sponsors and individuals who have helped support our mission. Thank you to our premier sponsor, Express Scripts, and all of our additional signature sponsors, and our Beyond the Table sponsors. So thank you to all of these sponsors for making today possible. There has been an unprecedented community response to COVID-19, and we're excited to be here today with this incredible group of panelists to share with you what we know and answer any questions you might have. We encourage you to use the chat or Q&A feature today to ask our panelists questions. We will try to get as many as we can for the time that we have today. So let's get started. I'd like to bring in our first panelist. We are delighted to have Dr. Jim Henricks on this panel today. He is a board-certified physician in infectious disease and medical microbiology and has served the St. Louis community for several decades. Currently, he is serving as an infectious disease advisor for the St. Louis County Department of Public Health. So welcome, Dr. Henricks.
Thank you. It's a pleasure to be here.
So let's get started. So we have some general questions about the COVID-19 vaccine. So I'm just going to jump on in and let's go.
Okay.
So which COVID-19 vaccines are currently available in the St. Louis area?
Well, we have three available. We have the Moderna and the Pfizer messenger RNA vaccine, and then the more recent Johnson & Johnson or Jansen vaccine, which is a one-shot vaccine, which is similar, but it's not an mRNA vaccine. So we can talk about the differences, but the important difference is that it's a one-shot vaccine, whereas the other two are spread out by either 3 weeks or 4 weeks between the two shots.
And you actually, great segue. I think that's something we're all interested to learn, to hear again, I should say. What is the difference between the mRNA vaccine and the viral vector vaccine? And do either of these actually contain the coronavirus?
Right, neither of them contain the coronavirus. The mRNA vaccines are kind of covered by a kind of a fatty lipid layer that allows it to get into the cell. And basically the messenger RNA is just like a tool that allows the cell that gets the vaccine into it to produce the so-called spike protein of the virus. And then that's pushed out into the system after the vaccinee gets it to make antibodies against that spike protein. So when they're exposed to COVID, that's what the antibody will see. Now, the Johnson & Johnson also contains that spike protein in order to cause immunity to that, but it's coated by an inactivated virus that's been inactivated and has been used fairly extensively since the Ebola outbreak. So there's a lot of experience with that. The mRNA vaccine is a little newer, but the technology has been there for 10 years or so. And this is the first time it's really been used. And the nice thing about it is it can be retooled if necessary, if these variants come into play.
Got it. So who is eligible to get the vaccine now, and how can people get more information?
Well, at the present time, we started out with healthcare workers and with physicians, first line responders, then expanded to first responders, some of the community that is actively involved with fighting the pandemic. It's now expanded to teachers as of this week, as well as other critically infrastructure workers. And then beginning, I think in May 1st or so, it'll be expanded to the general population. So we kind of at the county are sort of responsible for getting the teachers involved, getting the first responders, and the hospital systems are still kind of working through their patient load to really vaccinate the most at-risk people, namely the elderly and people with significant underlying diseases.
So I know this is on the minds of many. Are the vaccines safe, and what are some common side effects?
Well, they've been, when you look at all the clinical trials, including the Johnson & Johnson, you're talking about 140, 150,000 people that have been involved in these vaccine trials. And the FDA doesn't even consider the approving a vaccine until there's at least 2 months of follow-up. But now we have probably 6 to 8 months of follow-up on most of these people that were involved in the trials. So we have a very good idea how safe the vaccine is. There have been a variety of immediate kind of serious side effects that for which reason, we make people stay around for 15 days. We make sure we have an ACLS approved vaccinator available should this be necessary. But the risk of that kind of infection or that kind of response is probably 1 in a million or 2 in a million. And that's really been borne out by the subsequent experience with these vaccines. Now, people do get a variety of side effects, particularly with the second dose for those that have a 2 vaccine dose, as you can see on this slide. Many, including myself, developed, not severe, but chills, sometimes fever, a lot of body aches. So that's not unusual. And we usually just tell people that it really means that the vaccine is doing what it's supposed to do. It's stimulating your immune system to develop a response to COVID if you're ever exposed. So it's a very safe vaccine.
And for those of you who are trying to read that slide, we can share some of this information afterwards. So you've already kind of touched on this, but if you've had an allergic reaction to like a general flu vaccine, should you refrain from getting a COVID vaccine?
No, there's really been no cross reaction to any of the other vaccines that are in common use. And, as we get more experience with this vaccine, we'll have a better idea on what exactly people are reacting to. And obviously, if somebody has a severe reaction to the first vaccine, they should not get the second vaccine unless there's really a good reason for that to happen.
Got it. And I know one thing that you hear a lot of people talk about the speed of which these vaccines were developed. Any comments on kind of any reactions to that?
Well, the key thing, as I mentioned about the messenger RNA vaccines, is that they've been in development for 10 years. It's finally gotten to the point where they've been able to coat the messenger RNA with a kind of a lipid layer that allows it to get into the cell that's completely inert and not going to cause any reactions by itself. But these have been developed and we're kind of in the development stage when there was a big push from the federal government to expand the research, and the NIH was very heavily involved with the Moderna vaccine. So this was well looked at, well researched, and the beauty of it is that it can be developed relatively quickly, as opposed to, say, the flu vaccine that has to be grown in eggs and takes much longer to develop the vaccine. This particular vaccine can be engineered basically in order to fit whatever virus is in the community at the time. So it will potentially be available as either a booster or a second type of vaccine should the COVID-19 virus change significantly with these variants to require a different type of vaccine at that time.
Got it. Are you seeing any resistance to getting the vaccine in the community? And how do you think we can help build trust?
Well, we do see some resistance only because some people want to wait and see how it comes out. There's also obviously within the African American community and the Hispanic community, there's language barriers, there's issues with past performance of the federal government, particularly with African Americans. So to overcome that, all we can do is put out the science, put out the facts, and people just have to make their own decision. We're not discouraging people from making that decision. We're just making it available. We're trying to emphasize the pros that you're protecting yourself, but also your fellow neighbors and family members. I know in my case, it's over the last couple of weeks, my partner and I have been able to actually be indoors with another couple that was vaccinated and not wear a mask. I mean, all these things are really pluses that we really have to emphasize as people start getting together in smaller groups again.
That sounds wonderful.
Yeah.
Totally agree. Well, thank you, Dr. Henricks. I'm sure we will have more questions. So thank you so much for your time today, and we're going to move on to our next panelist.
My pleasure.
So I am excited to introduce you to Miss Rebecca Bennett. She is the Executive Director of Prepare STL, an initiative created to help stop the spread of the coronavirus in underserved communities. So welcome, Miss Bennett.
Thank you for having me.
Yes, so let's start with, tell us about Prepare STL. How did the initiative come about and what is the purpose or mission?
So we were started, not surprisingly, a year ago in March of 2020 by our city and county public health agencies, our community health agencies, including the Regional Health Commission, the Integrated Health Network, Alive and Well Communities, our Community Health Worker Coalition, our Mental Health Board. All of these organizations, both public health and community health, came together with the intention of being able to roll out a communications and engagement campaign focused on African Americans and foreign-born members of our community to try to mitigate the adverse impacts that we were sure they were going to feel, right? We understood health disparities and patterns of health disparity and anticipated that we would see disparity too in the impacts of COVID. So we wanted to slow down the stop of the spread of the virus and to help these communities survive the adverse impacts that were coming as a result of COVID.
So I know some of your work has shifted to help residents make informed decisions about the vaccine. So 1 year later, right? And so tell us more about your strategies and what you're hearing from your residents.
So interestingly enough, we have our overall strategy is called Living Well in the Era of COVID, right? Because we know that we're probably going to be experiencing COVID and its impacts for a while, even with vaccination. So we are emphasizing three things. One is people's physical and material well-being. The longer we stay, we exist with COVID, the more people struggle on food and economic well-being and access to resources, right? Things that aren't necessarily about medical need, but are about all of the ways that COVID has adversely impacted our communities and made life more difficult. So really wanting to help people build physical immunity and have their material well-being, stability in housing, stability in food, and those things. But another piece of that strategy really is on vaccination and with an emphasis on education and supporting people in making informed choices. So we don't tell people what to choose, but we are committed to providing information that will be useful in their discernment and decision-making and helping them think about their own personal circumstances and also think about what's the science here? What do we know? And then the third piece is really about healing trauma together, because I think there are probably few people on this planet who have not endured some measure of trauma as a result of not only COVID, but the impacts of COVID, whether or not it's on our economy or it's on our social lives and interactions. So we have got a sort of big picture view that says, wherever you stand, we want you to be able to live well. And we want you to think about living well, not only in the immediate term, but in the longer term.
So from your perspective, what is contributing to vaccine hesitancy in our community, and how can we overcome it?
Well, I think our previous panelists sort of talked about
Yeah.
it some, but specifically with the community that I am reaching out to, I think there are a couple of things. One is, do you understand and trust the science, right? So that's a question. The other is, are you in relationship with and do you trust those who are administering the science, right? Who are administering the interventions? And the truth of the matter is that many African Americans and people of color have very complicated histories and experiences with our health systems, not just our federal systems, but also our healthcare systems. So probably people know much about medical experimentation and those things, but racism within these systems has been real. And difference in terms of healthcare delivery we experience. So it's not just about experimentation, it's about whether or not there are patterns of disrespect or neglect or different treatment, differential treatment within these settings. So you also have to consider who's administering and do I trust them, even if I have some orientation towards the science. And then the third thing is really about people's personal circumstances, right? Their healthcare circumstances, their health circumstances, their social circumstances, whether or not they have access, transportation, all these other things that then can complicate decisions about vaccination. So I think it's a variety of things, Jennifer.
Definitely many layers to that. I was reading about your strategy with peer-to-peer outreach and community health champions. Can you just share some details of that today?
Right. So one of the things that we are doing, in addition to all of we're running media campaigns, and we just sent out a mailer to 165,000 households yesterday, and they hit, and we're seeing all of our healthcare partners and others see lots of uptick because of our media efforts. But we've also got this idea that community members are able to reach other community members. What we hear often is, well, we can't reach these populations. We can't reach foreign-born community members. We can't reach African Americans. Well, you know who can reach African Americans? African Americans. And you know who can reach, foreign-born community members? Foreign-born community members, right? So they don't have the differential in relationship. They already have relationship. And we know that people are responsive to word of mouth and to peer-based information. And folks everywhere, white, Black, and other, are having conversations in their families, in their workspaces, in their relationships about, are you getting vaccinated? Are you getting vaccinated? Yes, no, why? Right? So we wanted to tap into that network of conversation that's happening. So we are hiring 300 community health champions. And these are community members who have relationships with other community members, and to conduct 2 conversations with people in their networks, right, around informed choice in vaccination. So we want them to talk with up to 20 people, somewhere between 10 and 20 people via Zoom. We do all of the platforms, so they don't have to do anything with technology. We've got all of that. And we don't ask them to be vaccine experts, because you know what? We've got vaccine educators on call. We bring the expertise to them. So we've got 300 community members who are going to have 600 conversations with 6,000 people that folks have said are difficult to get. Well, they're not if you wrap them around with the adequate service and support. And they are also being supported by our community health workers, who can help them access healthcare supports, can help them access food, housing, and other kind of stability supports that also are part of living well in the era of COVID, right? All the other ways in which life is imperiled by this virus. So we're just asking people, hey, would you be willing to have 2 conversations with your neighbors or with your family members? We'll do all the background stuff. We'll train you. We'll give you vaccine educators who can be on call. We'll give you community health workers who can be on call. And we'll give you everything that you need to ask some good questions. And that's it.
Oh, that's great. That's great.
We're still recruiting, by the way, and we pay. So we're paying $200 a person. That's a piece of our model's economic relief. Yes. By the time we're done, we will have probably paid about $250,000 in direct economic relief and support to community members for being in service to their fellow community members during this.
Wow, and that's huge too. That's just an additional layer to that. Wow, that's impressive.
Yep.
And so this kind of goes along with that same sort of in that same sort of vein. So do you feel that there is enough being done to ensure equitable distribution of the vaccine, and what, if anything, is needed? And then what role do you feel that community organizations like the American Heart Association and others can play in the solutions?
Is there enough being done? No. So that's my short answer. Is that we know these are communities that are have been more adversely affected or disproportionately affected. And yet it's been a scramble, just like it was a scramble to get adequate testing. And, so we haven't seemed to manage to figure out how to operate equitably yet. And, we've been working on it for the last 400 years. So I want to put into perspective that this is a long issue, a much longer issue, and one that's not going to be solved just with this outbreak.
Yeah.
But there are some things that we can do. I think we are wanting other community partners and other folks to really put more education about vaccine and the options, particularly as we get more options on board. People are trying to understand and discern what are the differences between the options and what that means for them. But also including vaccinators publicly posting vaccine availability at events. We want to make sure that people can easily get what it is they need. Another issue for us is transportation. So there are lots in the communities that we serve that don't have mobile options and that have to drive to locations, but there are not enough locations in the areas of highest need. So how do we bring vaccines to where people are so that we take transportation out of the equation, right? Otherwise, we're increasing the cost of getting vaccinated, even though vaccines themselves don't cost us financially in terms of at the point of getting the vaccine. We're not paying there, but the cost is also transportation to site and other kinds of things. So can we get more vaccine distribution in the areas of highest need? And bridging the digital divide. Right now, there is a registration that is often required, often online, all of those things. So if you don't have digital access, and we're talking about communities who have less access, right, then that digital requirement becomes a barrier, and again, adds to the cost of vaccination.
Yep.
Right. So this is where those the ability to sign up for appointments in other ways, the ability to have events happen at site, and different ways of being able to make appointments, including walk-in options. Right. All of those things help with accessibility and help with advancing equity. So we want to see more of those things. In essence, what I'm saying is let's reduce the cost of getting vaccinated for those who are most vulnerable and who are least likely to have the additional resources to bear the cost, especially if they want it. Because, for many, it is a matter of life and death.
Absolutely. Well, thank you. I really appreciate you joining us today, and all the work that you guys have done with Prepare STL in this last year. And when we look back at this time of history, I know that Prepare STL is on the list of those heroes. So thank you. Thank you so much for all the work you're doing.
Thank you.
So let's go to our last panelist. We've got, Dr. Shahood is the Director of Cardiology and Chief of Medicine at St. Joseph Hospital in Lake St. Louis. Welcome, Dr. Shahood. And Dr. Shahood also serves on the American Heart Association Board of Directors.
Thank you for having me, Jennifer.
Absolutely. So let's start with explain what people with heart conditions should consider as they make decisions about the vaccine.
Thank you. And again, I appreciate being on this panel. This is an important topic that we need to talk about. And what we've seen all along, that our patients with cardiovascular disease are at the highest risk in general terms. And we know that currently this rate of death related to COVID is relatively low. It's on the average about 1%. But unfortunately, our patient with cardiovascular or pre-existing cardiovascular conditions, they do fare worse because they have worse outcome and more serious adverse effect related to COVID. And some of the data that we've had showed that their mortality, if they contract COVID, is close to about 10%.
Wow.
So that's about 10 times higher in those patients that get admitted to the hospital with COVID pneumonia. Let alone that recently we've had some data that showed that patients, particularly with heart failure, who contracts COVID and end up being admitted with COVID pneumonia, 1 out of every 4 will not make it out of the hospital alive.
Wow.
And that's why it's a staggering statistics that, yes, we keep talking that the mortality rate is low, which is true. But in those patients at high risk, they are more predisposed to those serious adverse events. Cardiovascular disease is by far the highest risk, especially if those patients are older, male, and obese, that tremendously increase their risk on the long run. Also with that, patients with hypertension also do carry a higher risk of mortality from COVID-19, especially that are hospitalized, which is about 6%. So that's still much more than what we see in the general population that we serve. And that's why it's been very important as we learn more about the COVID-19, that we educate our patients about the magnitude of impact that COVID can have on them if they have an underlying cardiovascular disease, why it's important to be careful with all the measures that we've been advocating, whether it's social distancing or making sure that they don't get in touch with sick contact because their risk will be much higher.
And so do you, as far as the vaccine, I hadn't heard some of those recent statistics, so thank you for sharing that. So do you recommend the vaccine then for people who suffer with those underlying conditions?
100%. I mean, the same thing we've done before, even with the simple flu vaccine, we recommend that all patients with underlying cardiovascular disease get the flu vaccine every year, because if they contract the flu, they are faring worse outcome. Same thing with the COVID. So because of that, yes, we've been recommending all our patients with previously existing cardiovascular disease be getting their COVID vaccination. And I've had those questions asked from a lot of patients when they come in to be seen is, what do you guys think? Should we get the vaccine? And the answer unequivocally is yes. From my standpoint, we've had enough data to show that the vaccines are safe in our patient population, including patients with cardiovascular disease. And since they are at a worse situation if they contract COVID, they should be on the higher priority to get the COVID vaccine to reduce the risk when they get exposed to COVID.
Is there any scenario where you would not recommend the vaccine for a patient?
Not at this point in time, and Dr. Henricks has already alluded to that most of the patients' reaction to the vaccination are usually mild, and it's usually at the injection site, some soreness, maybe light fevers, and more pronounced after the second dose of the vaccine. Those may be more magnified in people that had a recent COVID infection. So there's recent data also to suggest that even if you've had COVID, that the immunity that you get from COVID infection does not last long. And we have the data that showed it's probably close to about 90 days. So if those patients decide to get the vaccine within that time frame, they may have a bit more of a reaction to the vaccine. It's almost like getting the second shot of the vaccine because they already have circulating antibodies in their system. But that's still not a reason not to do it. If they had recent COVID infection, I've recommended at least to wait a bit before they get the COVID vaccine. But yes, it's still recommended for those patients to get it. And I don't believe that there is any scenario that will sway us away from recommending the vaccine for our patients with cardiovascular disease.
And is there any reason to believe that that people with heart disease or stroke underlying conditions have more likely to suffer from some of those just mild vaccine side effects?
Not at all. I mean, I've had several patients that already had the vaccine, and surprisingly enough, the older the patient is, the less they feel from the adverse events. And I don't have an explanation. Maybe Dr. Henricks has an explanation for that, but we've seen it all along. Older patients have not been complaining much of mild soreness, and that's about it. Not even fevers, not even muscle aches. People with underlying cardiovascular disease behave the same way. None of my patients, at least that I've came across, have complained of any adverse event more than what we've seen in the general population.
That's good to know. So are you seeing resistance to getting the vaccine from any of your patients?
I would not say resistance. I would say curiosity about what the recommendation of the medical community, especially in the field of cardiology, because on one end, they know that they are at risk. On the other end, they are afraid because they have underlying chronic conditions that they may fare worse if they take the vaccine. But in reality, the moment we put them at ease that, yes, there's enough safety data that we've seen it in a lot of volunteers that were screened and enrolled in the clinical trials. But even this vaccine, since it's rolled out, all our healthcare providers have taken those vaccinations, and also our patients have been taking those vaccinations for the past 2 months. We haven't heard about any serious adverse events from the vaccine. So when you put their mind at ease that, yes, it has been shown to be effective, and at the same time, it has been safe, I haven't seen any major resistance at all.
Yeah, Rebecca was right. Something she mentioned previously is everybody's asking their circle, did you get it? What happened to you? What happened to you? So I'm sure you do get a lot of questions from your patients.
I actually get a question from my patients if I got the vaccine.
Yeah, I'm sure you have. Of course, I'm curious too. I know you have. So we have a question here from the chat. Are individuals with pacemakers or artificial valves for their hearts at higher risk for adverse COVID-19 results?
No, what we've seen is patients with underlying pacemakers or devices in general terms, they don't carry a higher risk unless they had those devices because of an underlying cardiovascular condition. For example, a lot of our patients had pacemakers or defibrillators implanted because they had congestive heart failure. And if they did, and that's the reason for the device, then they are at risk because of the underlying condition, not because of the pacemaker. Similarly, patients that had valve disease or valve replacement, if they have an underlying cardiac dysfunction, heart failure specifically, then they may be at higher risk. But just by virtue of having a valve replacement, we have not seen anything to suggest that those patients will fare worse. Again, most of the common culprits have been heart failure, hypertension, diabetes, prior coronary disease, prior heart attacks are the ones that will carry a higher risk if they contract COVID.
Now, do we know why patients with the cardiovascular underlying risk factors fare worse? Do we know the reason for that?
So there's several potential explanations. One of them is that they have lower reserves. So in general terms, if you have somebody that is already starting with a weakened pump function, they already are at disadvantage. Similar issue with patients that have underlying lung disease. It's worse for them when they contract COVID because they have less of a reserve to be able to fight that infection. So patients in our patient population that had prior underlying coronary disease or heart failure, they don't have that reserve to be able to fight that infection, and that's why their outcome will be worse. That's one. Number two, there is some data that showed that even patients that had an underlying cardiovascular disease, there is a smaller proportion of them that will sustain what we call a myocardial injury from COVID-19. So COVID-19 does have a direct effect on the heart as well. Sometimes it's not symptomatic, so we see it only based on a blood test that we run in those patients that are critically ill. They come in with COVID pneumonia, they're requiring high flow oxygen or maybe in the ICU on the ventilators. When we run the cardiac enzymes, specifically the troponin, we've seen that the higher the levels of those markers, they are suggestive of an injury to the heart, the worse the outcome, even if the heart function is still preserved. Just by virtue of having those markers being elevated carries the worst prognosis. And actually, those patients had a mortality of up to about 60% if they have an underlying cardiovascular disease and they end up getting COVID with a leak of those cardiac enzymes because they already had an injury, and it's almost like pouring fuel on top of the fire. They already had the underlying disease. They got COVID. The COVID itself caused a myocardial injury, whether directly by the virus affecting the heart because it uses the same receptors that are available in the lungs, or indirectly because of the stress that is imposed on the heart. And we've seen this all along. Patients that are critically ill on the ventilator, this is an increased stress on the heart. And some patients, if they already have an underlying cardiovascular disease, they don't tolerate those stresses very well. So that leads to further decline in their organ function, higher chance of further injury, and worse outcome in the long run.
And what about those that don't start out with underlying cardiovascular disease? Is there still risk for damage to the heart?
That's a very interesting question. Actually, there's been some recent data that was a bit concerning because we've had some data coming out of Germany doing cardiac MRIs on patients that recovered from COVID-19.
Mhm.
And what the interesting part is those studies showed that about 60 to 70% of the patients had positive cardiac biomarkers, elevated troponins. And at the same time, the cardiac MRI in those patients that recovered completely from COVID did show signs of inflammation and some scarring. So even though those patients are not symptomatic at this point in time, we don't know what it means on the long run, because we know that they are what we call or label nowadays as the long haulers. They recover from COVID, they may have some residual symptoms, or they may have an undiagnosed cardiac abnormality that we've picked up on the cardiac MRI. We don't know how those patients are going to fare on the long run. We expect that some of them may end up developing congestive heart failure as time goes by.
Wow.
And there's actually more a recent study that was done in healthy athletes. I think it was done at the Ohio State.
Yep.
Which included the small number of subjects, was about 26, I believe. Just athletes got diagnosed with COVID. Most of them had no symptoms, and the rest had only mild symptoms. And they were just tested by the PCR that came back positive. Those patients had an MRI done within about a month after their exposure to COVID. And those studies did show signs of some inflammation in the heart. And again, as I said, they're completely asymptomatic. The question is, what does that mean on the long run?
What does that mean?
Is that going to lead to further decline in the heart function, or is it just delayed inflammation that may resolve with time? We still don't know. We're still waiting for those answers. So there are more to come on that subject. But yes, COVID, the people that recovered completely from COVID, there's still a chance that some of them may be left with some residual impact on their system, whether with mild residual symptoms or with some effect on the heart specifically, that we're waiting to see what does it mean clinically on the long run.
Yeah, I feel like now's the perfect time to say the Heart Association is going to be needed more than ever, right?
And that's why the Heart Association is basically spending more money to conduct those research in patients with cardiovascular disease during COVID, at least to get more light shed on these situations, to understand what is exactly the risk on the long run, what do we need to do. So we knew more than what we knew about a year ago, but we still have a lot to know about this virus. And I don't think that we're over that hump yet.
Agreed. Well, thank you. So let's move on to our broader discussion with all of our panelists. So during this discussion, I encourage our viewers to ask questions. And we did receive several questions already, so we will just kind of get started here. But if you have any more, please go ahead and put them in the chat. If we don't get them today, we can certainly send more information afterwards. So let's see here. Let's start with Dr. Henricks. Will the vaccine truly protect us from the virus? And will we have to get a vaccine every year?
So that's a complicated question. So the vaccine, at this point, they're very similar in that they prevent serious illness if somebody is vaccinated. Almost 95 to 98% protective against mortality if somebody is infected with COVID. The big question marks are, do they prevent somebody who's vaccinated, who's exposed to COVID, from carrying that virus back to a family member that's not vaccinated? And that's still a little unclear. It may be in the range of 60 or 70% effective at preventing carriage of virus, which is very important, but it does not appear to be as effective in that regard. So the CDC has come out with information that, yes, you can visit other people that are vaccinated. You don't necessarily have to wear a mask, but if there's somebody in that family who is at high risk for getting the infection and they have not been vaccinated, you should wear a mask. You should keep on with the social distancing. You should keep on with hand hygiene. So that part of it, you really have to examine what is going to happen with that particular event as to what you recommend as far as masking and everything else. There's a possibility, obviously, with the variants that we're seeing, particularly with the South African Brazilian strain, where the vaccine may not be as effective. I know Moderna is already looking at potentially a second generation vaccine that might be more effective against the changes in the spike protein that have mutated in that particular strain or strains of virus. So it may be similar to going forward, something like influenza, where there will be changes in the virus in the world that then lead to a change in the virus vaccine that is recommended for that particular year or that every other year. It's hard to know what the time frame of that will be.
Okay, well, thank you. So Rebecca, or Dr. Henricks, you may even have some thoughts about this in the role that you serve. So is there a regional plan in place to ensure equitable COVID-19 vaccine distribution? Is there anything the general public can do to assist in this process?
So I would say that there are a number of efforts right now to try to get us to a regional strategy. If you want to know if it's foolproof and full baked, the answer is no.
Yeah.
But are there lots of people working very hard, people and organizations, not just including our health departments, but also the Regional Health Commission, the Integrated Health Network, the Regional Response Team, right? So there are a number of community organizations, community health organizations that have raised their hands to work on regional planning for equitable distribution. So those things I would say are in the works. And then we want the general public to continue to educate themselves on the vaccines and the options available and to share information with friends and family members. Again, it turns out that messengers matter, right? Yeah. And that even though we have a number of wonderful experts in the field, there are so many of us who have zero relationship with them. And in the absence of relationship, it means that we don't often believe or connect with the information that's being provided. So relationship, as a takeaway, relationship matters here. And so if you have information, the important thing to do is to be able to share that information. I do want to say, though, that a number of community members are raising their hands to volunteer and to serve in other ways. And so where you heard me say there are community members who are mobility challenged, don't have transportation, don't have easy access to computers, a number of our faith-based communities and social service organizations and groups like the Urban League and others are looking for people to volunteer, right, to be able to reduce the cost of entry for those who want. So you call us and you tell us, and then we will fill out the online registration. Or if you need access to a vaccination site, we will help conduct that, or we will help in planning those things. So I think having community members find ways that they can volunteer to be of assistance to those who have more barriers to entry, I think is probably a good thing. But especially, I think, sharing what you know, and more importantly, what it is that is informing your decision making. And I recognize that we have a variety of perspectives on this. We are not a homogenous group. We don't all think the same way. And so the other thing I would say is to be mindful that we aren't sure of what everyone's circumstances are. So we need to be careful about that. And then the last thing I will say here is that while we have heard from the CDC and others that if we're vaccinated, we can relax some of the protections, I would just encourage us to the best extent possible to maintain the protections. Because unless we are going to move into spaces where we ask people, have you been vaccinated and what is your health history and all of those things, which many of us might find invasive from people who are not in our immediate networks, then we have to presume and assume that people don't have all of the protections we want them to. And as a part of service to others and not just ourselves, we take the extra precautions to maintain good hand hygiene, to wear our masks, to be socially distant when we don't know what the vaccination standings or the health standings are, so that we can help preserve life as much as possible. We should never poo-poo that and let that go away in these times. We still need to keep doing what we absolutely know works. Absolutely,
it's a good reminder. So we have a few more minutes. So Dr. Shahood, of the 3 vaccines available, is there one, quote unquote, safer than other for individuals dealing with cardiovascular disease or stroke?
Not from what we know nowadays. I think all 3 vaccines fare well with patients with cardiovascular disease. And I would ask Dr. Henricks as well to comment on that. But from my understanding, all three vaccines are safe, and they are as safe in patients with underlying cardiovascular disease as the general population.
Fantastic. And what, I guess this goes kind of, Rebecca, to your comment that you said, but Dr. Henricks, what activities are considered safe after being fully vaccinated?
I think the general safest is an outdoor setting, and luckily we're getting into warmer weather. I still think even if you don't have a mask, to Rebecca's point, it's important to be socially distanced, even if you're outdoors. Even, you know, you have certainly a less chance of needing a mask in that circumstance. But again, it really is important to know who's there with you, what they've been exposed to, because they may be carrying the virus even though they've been vaccinated. So there's just a lot of different things that are important. The other thing is, as we go further into the vaccine, we don't know how protective and how long the vaccine will protect. You know, Dr. Chahoud mentioned that 90 days after somebody's had the infection, if they have a contact with somebody who has the infection, we would not consider them needing to quarantine. But we don't know if that same rule applies to the vaccine population. And, you know, with most natural infections, the natural immunity that you get from the infection is longer lasting than what you get from a vaccine. So it's a little hard to say how, if the vaccine will fare better than if somebody has the infection or not. So there's just a lot of unanswered questions, and most of the way we measure to see if somebody his protection is antibody levels, but we know our immunity is much more complex than that. You know, we have cell-mediated immunity that we can't even easily measure. So it may be that the vaccine and natural infection is more long-lasting than we realize.
And one last question before we close out the group. Still lots of questions about, as far as the vaccines that are available, are there any that are more effective and would have less side effects? Is there any sort of proof of any of that?
I think they're equally effective in terms of preventing the major things that we're trying to prevent, namely death, significant hospitalization. They seem to be very similar in that regard. The side effect profile appears to be relatively the same. The one advantage that we're using at the county level, as far as homebound patients, that type of thing, is the one dose vaccine of the Jansen home, vaccinate the affected individual plus their caregivers, and we're rolling that out over the last couple of weeks. We know we have less access, so the Johnson & Johnson product comes in very useful for that particular population.
Fantastic. Well, I know we had a lot of questions, but we are running out of time. So thank you guys. This has been a great discussion today. Before we close, I'd like to give you just kind of one last chance to share your final thoughts with our audience. And let's start with you, Rebecca.
I had to unmute for a moment. I think I want to reiterate that I would appreciate people doing all that they can to keep themselves safe, but also to keep others safe, right? For those who care about social justice, who care about racial justice, I want to say this, right? We know that people have different access to vaccines, right? And that access often breaks down along race lines and class lines, right? And so those of us who are poorer are less likely to have already be connected to healthcare settings that are facilitating access to vaccines, right? So we're less likely to have the transportation to be able to go to where the vaccines are given. We're less likely to have vaccination events take place where we live, right? All of those costs. We're less likely to have digital technologies that make it possible for us to register online, right? So I am saying that we know for sure that rates of vaccination, even if I take distrust out of the equation, that all of those other barriers mean that we're going to see differential rates of vaccination in populations, which also mean among populations that are also more likely to die and to get severely ill because of pre-existing conditions, chronic illness, all those other things, right? So as an act of service, I am suggesting that we need to continue to do the things that we absolutely know work, right, to the best extent possible, to keep our neighbors safe, particularly the neighbors who are most vulnerable among us, for whom the cost of getting vaccinated is going to be so much higher, right? The unseen costs are going to be so much higher. So if you care about racial justice, you care about social justice, you know, look, wash your hands, stay distant, wear masks, right? Because we cannot presume and we cannot pretend that vaccination is going to roll out evenly to everyone. And so part of what I worry about is that many of the community members who I'm trying to keep safe are also essential workers, right? They're essential workers, they're care providers in spaces where people are more affluent, are going to have more vaccination, and are going to be relaxing these protocols. But they're going to be relaxing these protocols around people who they can't assume also have the same protections. And so then it compounds the situation. We start to see these communities be even more endangered. So I think the thing that I want to leave is, you know, let's do the best that we can, even as we get to breathe a little for those who have decided to get vaccinated, you know, do the best you can to make sure that those around you, those whose services you rely upon, right, are safe and not just you.
Absolutely. Thank you. Let's go to Dr. Shahood. Any last thoughts? You're on mute. I had to say it once. Somebody had to say it once.
Perfect. It has to be me. Thank you again. And yeah, as a lasting remark in general terms, I really thank you as well as the AHA for having us being part of this panel. I think this is an important discussion in this day and age. As a point of positive sides is that, yes, we keep talking about COVID-19. The mortality is still low for the general population, about 1%, but we have to focus predominantly on the patient that have an underlying chronic conditions, whether it's cardiovascular disease or lung disease or diabetes and hypertension. And those may be more pronounced in some communities, especially African-American as well as Hispanic, and this is no surprise to any of us. So what we have to be careful with is, what do we get out of this? And in general, the message that went out initially that I wanted to share earlier is, yes, we have to be careful, we have to stay distance and avoid contact, but our patients started taking this to heart and they stopped showing up to the hospital.
Yeah.
So we had the flip coin of that a lot of these patients end up having a stroke or a heart attack, and they did not even show up to the hospital. We have a significant decline in these patients showing up to the hospital. So point here is that, yes, the message is to stay safe, but if you have problems, the best place to be is at the hospital. You have to seek medical attention, because these acute issues with acute heart attacks or acute strokes cannot wait. Time is of the essence. We have to make sure that we get those patients treated in an appropriate manner. That's one. Number two, those patients that have an underlying cardiovascular disease, they are at the highest risk. So we need to pay more attention to these patients, make sure that they have access to care, access to vaccinations, and they are still following the universal protocols to stay safe.
Absolutely. Thank you for that reminder. And then lastly, Dr. Henry, you want to close us out?
Well, I just am really happy to have been on this panel, particularly to hear Rebecca. She just really has lit up the room as far as I'm concerned with her comments. So I take those to heart. You know, in my position at the county, we try to do as much as we can equity-wise. I'm going to be vaccinating myself as a vaccinator on Friday morning, if anybody wants to come over to Berkeley and get in line. But I think what she's saying about more open access, I mean, we're trying to actually, we've gotten permission basically to go for zip codes that we know are underserved and try to reach out specifically to some of those zip codes to get that equity a little closer in mind. But we've also been reaching out to a lot of churches to, you know, if we can provide a volunteer with a computer that help people to pre-register for vaccine while they're there at the service, that's something that we'd like to get going as well. So Rebecca, you have wonderful ideas. We all, I think, share a little bit of pandemic fatigue. This is a tough, tough year. And all I can say is we just, to your point, Rebecca, we can't relax our guard until we get to the finish line. And nobody knows when that's going to be. So just keep up the fight. Yes,
thank you. What a great way to end it. So thank you, guys. This has been a fantastic conversation, and thank you guys for sharing your expertise today. Like I shared in the beginning, it's hard to believe that it's been 1 year since our world changed, and certainly been devastating for many in our community. But it's also been a time when the best in our community have shined brightly. So many heroes emerged and showed us the true heart of St. Louis. And it is in that spirit that we are pleased to introduce a new Heart of St. Louis recognition. It is an honor given to the individuals and organizations in the St. Louis region who are the heartbeat of our community, creating a world of longer, healthier lives as a collective effort, driven by dedicated and passionate individuals and organizations across the region. And so at this time, I'd like to thank Nuance Communications for sponsoring the inaugural Heart of St. Louis Award. And here is Holly Kasnitz from Nuance to announce this year's winner.
Good afternoon, everyone. So as Jennifer mentioned, my name is Holly Kasnitz. I am a longtime St. Louis resident and the account executive for Nuance, a technology pioneer with market leadership in conversational artificial intelligence and ambient intelligence, known for solutions such as Dragon Medical One and Dragon Ambient Experience. We are proud to sponsor the inaugural Heart of St. Louis Award, and we are pleased to join with the American Heart Association today to celebrate and recognize the true heart of St. Louis, the healthcare professionals, researchers, caregivers, educators, and community organizations in making an impact in our community, especially during the pandemic. Nuance is pleased to present this inaugural award celebrating a deserving organization that represents the true heart of St. Louis. And this year's honoree is Prepare STL. Prepare STL has been instrumental in helping prepare all St. Louisans for the effects of COVID-19 response, how to stop its spread, and how to survive the pandemic physically, emotionally, and economically. Rebecca alluded to all of that. Thank you, Prepare STL, for being the heart of St. Louis.
Yes, thank you. Again, congratulations to Prepare STL. I know you guys have enjoyed having Rebecca join us today. She actually had the award sitting behind her the whole time, if you noticed that pretty red heart in her background. So we were excited to present this inaugural award, and thank you again, Nuance, for helping us do that. So before we end today, we want to hear from another longtime supporter and friend of ours at Darty Business Solutions, and how they've also helped to respond to the community during this pandemic.
The COVID-19 pandemic changed the world. It also taught us some lessons. And one of those lessons is that our under-resourced, disadvantaged communities are the most vulnerable, especially in times of a crisis. And it's those same communities where the infant mortality risk is highest. Imagine you're a young mother, your newborn baby stops breathing. You call 911, the paramedics are on the way, and the seconds are ticking by, and there's nothing you can do. That baby can't ask for your help, so I will. Join me in supporting the American Heart Association, and we'll ensure that that young mother has the infant CPR kit and the knowledge to use it that can save her baby's life. Let's support the American Heart Association and make a difference. That's why we're here.
All right, thank you, Ron, and your team at Darty for your continued support. And that's it today. So on behalf of the American Heart Association, we look forward to continuing to collaborate with each of you to extend people's lives today and in the future. Please stay connected with us at heart.org. You can also follow us on social media on most platforms at AHA Missouri. And we hope you guys have a wonderful week. Thank you so much, and we'll see you next time.